So thanks everyone for joining me. I'm Amanda Rogers. I'm excited to give the first grand rounds of 2021. My talk today is titled Neuromuscular Emergencies in Children. Okay. I don't have any relevant financial disclosures. This is the CME code if anybody wants to jot it down. I'll have it listed again at the end of the presentation. So today I'm going to be talking about four main disorders. These are the most common pediatric neuromuscular emergencies and things that most pediatric neurologists will encounter at some point, maybe with the exception of juvenile myasthenia gravis. These obviously all could sort of be talks in and of themselves, so I'm going to be focusing on the kind of acute management when these patients present in the emergent setting and go over a little bit of the pathophysiology of a couple of these disorders. So starting out with Guillain-Barre Syndrome, this is by far the most common pediatric neuromuscular emergency, and it's one of the most common causes of acute weakness in children worldwide. So this is something that any neurologist who does any time attending in inpatient will encounter. The incidence is thought to be about 0.5 to 2 cases per 100,000 per year. And it's really a spectrum of disorders where patients can present with constellations of different findings, but by far and away, the most common presentations are AIDP, or acute inflammatory demyelinating polyradicular neuropathy, or the axonal variant, acute motor axonal neuropathy, or acute motor and sensory axonal neuropathy. So I'm going to be focusing on these two variants today, and particularly in children, these are really the most common things that you're going to encounter. So AIDP and AMON and AMSON are immune-mediated diseases that result in the destruction of the peripheral nerves. As suggested by their names, AIDP refers to pathology primarily of the myelin sheath and the peripheral nerves, whereas AMON involve primarily the neuron's axon. And the pathogenesis isn't completely understood. There is likely a role for the humoral and innate immune systems, with the humoral role being probably a little bit better understood. In AIDP, there are some unidentified antigens likely on the myelin sheath that attract antibodies and then result in complement activation, nerve injury, and then macrophage scavenging of the peripheral nerve myelin. Patients with this demyelinating form of GBS are much more likely to be seronegative. So we do not often detect antibodies against peripheral nerve antigens in patients with the demyelinating form. So again, it's really not well understood exactly what the protein within the myelin is that's triggering this reaction. The axonal form is a little bit better understood due to the presence of ganglioside antibodies, specifically directed against GM1 and GD1A, which are gangliosides that reside in the nodes of Ranvier. These patients are much more likely to be seropositive, and probably more than half of patients with the axonal form of GBS will be positive for one of these antibodies. And this is the sort of relationship that gives evidence for the molecular mimicry hypothesis of GBS. So as we'll talk about in a minute, a lot of patients, and as most people know, a lot of patients have some sort of febrile illness within the preceding 2 weeks prior to presentation. And a common pathogen for the axonal form is Campylobacter jejuni. And C. jejuni has very similar glycolipids in its polysaccharide coat to GM1 and GD1A. And so the idea is that having that infection triggers antibody production against these glycolipids and then the antibodies cross-react with the glycolipids in the axonal membrane as well. And so rather than primarily attacking the myelin sheath, the antibody target is at the node of Ranvier, also activates complement, and also results in destruction and macrophage scavenging. There's also some degree of disruption of the integrity of the paranode and nodal interaction with the axon, and so there can be propagation of the axonal damage even beyond the node of Ranvier. As I mentioned, there is also evidence for the involvement of the innate immune system as well, and this is a little bit less specific, but in general, in patients with GBS, there are elevated markers of T-cell activation in their serum, like soluble IL-2 receptor and interferon gamma. And then the animal model, which is EAN, experimental autoimmune neuritis. This is more of a T-cell mediated process, and mice who have this experimental state induced look like GBS patients. So it's probably a combination of the two. The clinical features of AIDP are pretty consistent between patients. Most patients have some degree of gait dysfunction, and not being able to walk in children is the most common presenting feature. At some point throughout their course, 95% of children will have gait dysfunction. Numbness and paresthesia that are distal predominant are common, but pain is also, significant pain. That's the patient's, primary complaint is very common in childhood GBS, with up to 75% of patients presenting with pain. And they can really be complaining of back pain at presentation, which can sort of confuse the picture and might make you think that you're dealing more with a myelopathy than a peripheral nervous system disorder. Patients do have progressive weakness, and I'll remind you that this is a radicular neuropathy, and so the patient's proximal and distal weakness, even though in medical school we're often taught that GBS causes ascending weakness. Really, most of the time the nerve roots are involved very early on, and we can see that on imaging as well as on exam as patients have proximal weakness in addition to distal. Of course, this can progress to involve the respiratory muscles. By definition, patients with AIDP reach their symptomatic nadir within 4 weeks. So if they continue to progress beyond 4 weeks, then you should start thinking about CIDP. But really, half of patients reach their nadir within 2 weeks, and then 80% by 3 weeks. So it really is an acute onset disease. Cranial nerve involvement is fairly common, and the seventh nerve is far and away the nerve that is most often involved. As we'll talk about in a little bit, this also might have a little bit of prognostic relevance. Most patients at presentation will have reduced or absent tendon reflexes, 90%, and then it's also fairly common for patients to have some degree of autonomic. As I mentioned before, most patients do have a reported prodromal illness or may have been vaccinated within the preceding week or two. In the demyelinating form of GBS, CMV, EBV, mycoplasma tend to be the most commonly isolated pathogens. It's also important to think about systemic illnesses in patients who present with GBS. This is probably a little more relevant to adult patients, but this being triggered by Lyme disease and HIV are an important differential. Other autoimmune disorders can present with AIDP. Patients with lymphoma can develop an AIDP-like picture. And then this is also well described in graft versus host disease or just following a bone marrow. So important to think about kind of other relevant history there. For the axonal form, there's a very similar initial presentation to AIDP. The weakness might be more rapid in onset, with patients kind of reaching their nadir within a 24-hour period. These patients can also have cranial nerve dysfunction, respiratory failure, and dysautonomia. It's maybe a little bit less common to have cranial nerve dysfunction in the axonal form. That antecedent infection that's classically associated with the axonal form, like I previously mentioned, is Campylobacter jejuni diarrhea, and there's evidence of this prior infection in 67 and 92% of patients. And then these patients are much more likely to be antibody positive. There kind of historically is this teaching that patients with the axonal form have a incomplete recovery compared to those with demyelinating. It's definitely shown that these patients have a more prolonged recovery, but particularly in children, as you follow these patients out even further, it's possible that they may have a similar long-term prognosis to AIDP, but it just takes longer to get there. So if you're suspicious of GBS, the physical exam is going to be very important, but your other workup is going to include a spinal tap, and you're looking for elevated protein in the absence of pleocytosis. So if there is an elevated white blood cell count, then you want to be thinking about those things like Lyme disease and HIV. Sorry, I heard a little bit. Most patients will start to exhibit this albuminocytologic dissociation within the first week, but you can miss it if patients present early on, but 88% will have this finding after 2 weeks. And so I would argue that it's definitely worth doing as soon as possible. I'd also caution people who are taking care of children to really think about the normal values of protein in the CSF. So a lot of times labs will report, that their upper limit of normal for CSF protein is, at say, 60. But, really the criteria for an elevated CSF protein is like 35 to 45. Drink your milk. Drink your milk. Mama, tell him to drink his milk. You should also send serum testing for ganglioside antibodies regardless of the demyelinating form. And then often these patients are going to have an MRI of their spine done. It can be very difficult in the acute setting to differentiate CBS from myelitis neuropathy. And so often you're doing an MRI of the spine in order to rule this out, but commonly we see product nerve root thickening and enhancement, which is further evidence of the diagnosis. Electrodiagnostic, so EMG nerve conduction studies should be done in these patients. Similar to the CSF, the findings can be normal in the first week, but it is common to already have abnormalities within the first week. So this paper that I've cited on this slide, in muscle and nerve, they looked at, I think, a couple dozen pediatric patients, and all of them had at least one abnormal finding within the week. So it's still worth doing. And then within 3 to 8 weeks, 80 to 90% will show abnormalities. Early features that you might see are changes in the late responses, so prolonged F-wave latencies or absent F-waves, or just reduced recruitment on EMG, particularly in those proximal muscles, since the nerve roots do tend to be affected early. On the right-hand panel of the screen, I've shown conduction block in the peroneal and tibial nerves. You're lucky if you see this within the first week, but eventually this is one of the classic findings that you'll see in any demyelinating neuropathy. And so I would argue that even if the clinical picture is clear, it's worth doing the EMG nerve conduction study, and for a few reasons. For one, it can help you differentiate between demyelinating or yes, which, as we talked about already, can have some prognostic implications. Also, it can give you a baseline. So if patients don't seem to be improving with the treatment that you've given them, then you can repeat the testing to see if things are worsening and if there's evidence of an ongoing process that needs to be treated differently. So sometimes that can happen in CIDP. And then lastly, although you can see nerve conduction study changes within the first week, most of the time you don't see profound demyelinating changes. And so a lot of people say that if you do see profound demyelinating changes in the first week of presentation, it's more likely that you are dealing with CIDP, of which 25% of patients can present with a GBS-like picture. So for those patients, you'll still likely treat them the same way, but you may keep a little bit closer eye on them and follow up and look a little bit harder for ongoing decline because you may treat those patients differently. This can be, have very severe complications. So up to 10% of patients can have mortality related to GBS. This is really probably more in developing countries. In the United States, it's probably more like 2.5% to 5% fatality rate. But regardless, whenever you're suspicious of a patient with GBS, you should consider ICU monitoring at least while you're sorting them out and figuring out, how quickly are they likely to progress to their nadir and getting them started on some sort of treatment. Respiratory monitoring is very important because 20 to 30% can develop respiratory failure. And an important point that I wanted to make is that neuromuscular respiratory failure can be a little bit harder to recognize than your typical respiratory failure. So these patients may not exhibit the typical features that you look for when you're looking to see if a patient is struggling. So we're kind of taught in pediatrics that patients either look sick or they don't. But in neuromuscular respiratory failure, the cause of the failure is weakness of the muscles. And so the patients often don't really have the force or the stamina to generate those retractions and that heavy breathing that we see in patients who are really working to breathe due to like pulmonary edema or an infection or something like that. So rather the patient feels very anxious, they feel air hungry, they feel like they can't get a good breath. This problem is worse when they're supine compared to when they're sitting up. And they also really look anxious. They kind of have this bug-eyed look, and they look like they are very, worried that they're not going to be able to breathe because that's what's happening. So you can monitor this in a few different ways. I would recommend checking the negative inspiratory force, or MIP, and then the forced vital capacity at least every 4 hours in the first 24 hours that you're monitoring a patient, and really paying attention to the trend. You can also, certainly monitor blood gases and have patients on pulse oximetry, but in looking at these pulmonary function tests, if the trend is one of decline over, a relatively short period, it's probably a better idea to electively intubate these patients rather than waiting for it to have to happen in a fashion. Another significant complication can be autonomic instability. So these patients really should be monitored on telemetry because arrhythmias can occur. And then as neurologists, we should counsel our ICU colleagues to sort of be cautious in terms of management of blood pressure and heart rate. So the blood pressure can be very labile and can swing one way or another very quickly. And so you want to counsel them to use, fluids, short-acting agents to keep these problems under control so that the patients aren't given a long-acting antihypertensive and then, dropping their blood pressure out and you're chasing your tail. So which patients, are going to develop these serious complications and which aren't? That would be nice to know when people first present. So this table is from a paper where the group looked at over 100 pediatric patients who presented with GBS, both axonal and demyelinating forms, and tried to sort this out. Can we figure out which patients are going to need to be intubated, which patients are going to need, or which patients are going to develop dysautonomia? And they found that these factors in this table seem to predict intubation. So average interval between initial symptoms and hospitalization, so how quickly between when they first develop symptoms and when they present, predicts intubation, a higher GBS disability score, loss of walking. These are kind of intuitive, so the more severe the weakness the patient has, the more likely they are to need ventilation. Patients who require intubation are more likely to have dysautonomia and vice versa. These two I thought were interesting. So the peripheral facial paralysis, so patients who do have facial nerve involvement were actually more likely to be intubated. So I thought that was kind of useful because that's not necessarily intuitive, but something to look out for. And then also impaired vigilance. So they had a couple of patients with Bickerstaff brainstem encephalitis in this series, and those patients did require intubation as well. And then they also looked at all of these factors to see if any of these factors were predictive of long-term outcomes. So after patients were out of the ICU, out of the hospital, did any of these predict recovery? And they actually found that the one factor, in addition to having an axonal form of GBS that predicted a worse long-term outcome, was the interval between initial hospitalization. So these patients who come in and they are extremely weak within the first couple of days are more likely to require ICU care and are more likely to have neurologic sequelae of their disease even after treatment. Similarly, they looked at the patients who had developed dysautonomia or not, and they found kind of similar findings. So patients with dysautonomia had longer hospital stay, longer ICU stay. They were more likely to be intubated. They were more likely to have a higher GBS score, have loss of walking ability, have cranial nerve involvement. What I found interesting about this analysis, though, was that there were patients who had a GBS score of 1 or 2. So these patients are really minimally symptomatic, or they are symptomatic, but they can still walk at 5 or 10 meters unaided. So, doing pretty well, and these patients can still develop dysautonomia. So just because they don't look quite as sick as some other patients that present with GBS, it's still important to monitor for this complication. So treatment, what do we do for these patients? So the more high-quality studies, of course, have been done in adults, and these studies go back to the 80s and 90s. So the first treatment that was really looked at for GBS was plasma exchange. And compared to control, so just supportive treatment, they found that patients treated with plasma exchange had a reduced time to improve one clinical grade, time to walk unaided, time on a ventilator, and then all the patients out. More patients who had received plasma exchange were continuing to improve after 1 to 6 months. Next, IVIG was looked at, and because it had been shown that plasma exchange was effective, they, of course, just compared the IVIG to plasma exchange and found that IVIG is at least as efficacious as plasma exchange in these severely affected patients when they were treated early on. And so, kind of intuitively, next they looked at whether or not we should be treating patients with both plasma exchange and IVIG, and they actually found that there was really no added benefit to dual therapy. So really pick one or the other, and it really doesn't make a huge difference in terms of long-term outcomes which treatment you choose. In pediatrics, we don't have quite as rigorous of studies. Most reports of GBS are sort of limited to case studies like this one from Cleveland Clinic that describes 9 patients with GBS. And in this paper, they did note that more of their patients responded to plasma exchange than IVIG, and they actually crossed a few patients over from IVIG to plasma exchange who they felt hadn't had an adequate response. But, it's a small group and it didn't reach statistical significance. This was actually a randomized controlled trial that looked at patients treated with IVIG versus plasma exchange in patients who were intubated. And what they found, this was 41 patients, and they found that patients treated with plasma exchange had a shorter period of mechanical ventilation by 2 days, but there wasn't any difference in their PICU stay, the duration of their PICU stay, or their ability to walk unaided after 4 weeks or 28 days. So in both groups, 90 to 95% of patients were able to walk unassisted after 4 weeks, regardless of the treatment. This was a paper that came out in 2019 that was kind of interesting. This group was advocating for this treatment strategy that they called the zipper method. Again, this was a small group, I think 7 to 9, I think it was 9 patients. And they actually, rather than following plasma exchange with IVIG, they would give IVIG in between plasma exchanges, but they timed it to sort of, in their theory, give the IVIG enough time to work before plexing it off. And they reported that they thought they had great response to this method, and their average mechanical ventilation time was 7 days. And all of these patients were walking at 28 days. And so they said this is, maybe a little bit better than just treating with one or the other. I think, probably it's really about the same as treating with just IVIG or plasma. So overall outcomes, I've alluded to this before, there is a 2.5 to 11.5% mortality rate. On average, amongst different case series, in children and patients who require mechanical ventilation are on the ventilator for 7 to 13 days, and there is some evidence that this time is shortened with plasma exchange versus IVIG, so there may be some reason to do plasma exchange in intubated patients. On average, patients who require admission to the ICU are there for a little more than weeks. But at 1 month, kind of across studies, more than 90%. So overall, very good prognosis. And it's been reported 66 to 94% with a full recovery, but really most, especially again, in developed countries, most reports give a greater than 90% full recovery. When patients do have sequelae, they may have a little bit of distal weakness, they may have persistent pain or dysesthesias, and then fatigue, interestingly, is actually a very common long-term sequelae that patients. Again, patients with the axonal form may be more likely to have sequelae, but if you follow these patients out long-term, 2-3 years, a lot of them do have really good. Treatment-related fluctuations can occur in 10 to 12% of patients, so this is something to look out for and counsel your patients about. So if patients recover with treatment and then worsen, that doesn't necessarily mean that something else is going on or that they have CIDP, as long as this fluctuation occurs within 8 weeks of their initial presentation. It is defined by a decrease in the GBS disability score by at least 1 grade following an improvement of at least 1 grade. And in these patients, most of the time you can sort of just follow them and they'll stabilize out again. But one approach, especially if they've been treated with IVIG, is to check IgG levels. And if they're not very high, then you can redose the IVIG to sort of tune things up and give them the optimal treatment. So moving on from GBS, I'm going to talk briefly about acute flaccid myelitis. So this is an interesting disorder that has gotten a lot of attention in the last 5 to 10 years. So it's thought to be an infectious, parainfectious destruction of the anterior horn cells resulting in flaccid weakness. So sort of similar to poliomyelitis, but due to different entities. And these patients are very commonly have a febrile illness about a week before they present, and then pretty rapidly evolve limb weakness that can involve the arms and the legs. Cranial nerve dysfunction happens, but it's not seen in the majority. Most of the time, patients have loss of tendon reflexes when they present. This is a disorder, as I mentioned before, primarily of the anterior horn cells, and so these patients should have intact sensation, but they can have bowel and bladder dysfunction and commonly do progress to having respiratory failure as well. So the differential for this really is transverse myelitis, an anterior spinal artery stroke, and GBS. These are kind of your main differentials. And while you might not be able to distinguish these based on history and exam alone, most of the time your workup will point you in the right direction. So these patients will get an MRI that classically is going to show E2 flare hyperintensities involving predominantly the gray matter of the spinal cord. Some patients may also seem to have some white matter involvement or some cord edema, and that may be relevant for how you're going to treat these patients that we'll talk about in a little bit. These patients should get a spinal tap, and they will have commonly a lymphocytic pleocytosis as well as an elevated protein, so should be able to distinguish between a stroke and GBS based on your CSF studies. In 2014, 2016, and 2018, there were kind of increased reports of AFM that seemed to correlate with outbreaks of enterovirus D68 infections in the U.S. And this has kind of been closely monitored by the CDC. They haven't isolated enterovirus D68 in the CSF by PCR, but they have detected antibodies in the CSF. And then a lot of patients, if you look at respiratory or stool samples, will have evidence of a prior enterovirus D68 infection. And so whether this is actually, an infection and viral destruction of the anterior horn cell versus just a predominantly para-infectious kind of inflammatory process is not completely understood, but there is definitely an association there. West Nile virus, adenovirus, and Zika have also been associated with AFM. Patients with AFM have been shown to have serum antibodies to MOG, and so this is a reasonable test to send. And then you can consider EMG nerve conduction study in these patients. It's not very useful in terms of diagnosis, but I have seen it used to kind of help with prognostication on how much recovery is likely to happen. Treatment, unfortunately for these patients, this is kind of the worst disorder I'm going to talk about today in terms of prognosis. Treatment is really aimed at supportive care and rehab. So there haven't been any prospective trials, but there's not, in retrospective studies, there's really not any evidence for IVIG, plasma exchange, or corticosteroids making much of a difference. Particularly, most of the time, we still give these in these patients because we want to do something. But it likely doesn't make a huge difference in how they're going to do long term. If there is evidence of white matter involvement and evidence that this is more of a transverse myelitis picture or that there is spinal cord edema, then it's definitely reasonable to give corticosteroids. But some people do have a little bit of hesitation for this because there's thought that sometimes these processes may be due to the infection itself and not just a post-infectious inflammatory process. There was a little bit of press regarding fluoxetine a couple of years ago, and this came from in vivo studies that showed that fluoxetine inhibited enterovirus D68 replication in a mouse model. But they did look at this retrospectively in humans, and while fluoxetine was well tolerated, there was no outcomes between patients who received it and who didn't. So really, supportive care and early rehab are important. Most patients do have persistent motor deficits regardless of what you do, and there are surgeons who are increasingly doing nerve transfers for these patients, and this is where the EMG can come in handy to help the surgeon sort of plan what nerve transfers are likely to be useful and beneficial to the patient. So moving on to juvenile myasthenia gravis, this condition definitely has much better prognosis than ASM, but it is quite rare. So this is something that a lot of neurologists will not see in their lifetime. There's an annual incidence of 1 to 2 per million children in Europe. We don't have great epidemiological data in the US, but it's probably around this number. It's much more common in Asian populations than children, but we don't see it quite as much in the West. Patients as young as a year of age can be affected with juvenile autoimmune myasthenia gravis, or they can present up into their teenage years. Patients who are pre-pubertal have a higher rate of just restricted ocular myasthenia gravis without generalized disease, and they're more likely to be serum antibody negative, but they can seroconvert, so they can become positive up to a year or two after they initially present, and children certainly do have generalized disease, and crises can occur, so these patients can present as a neuromuscular emergency. Briefly, these cartoons kind of review the pathology or the physiology of the neuromuscular junction. So the motor nerve terminal interacts with the muscle at the motor end plate. The motor nerve terminal includes vesicles of acetylcholine that are released and diffuse across the synapse to interact with acetylcholine receptors. And once this interaction occurs, muscle fiber action potential is typically generated depending on the degree of the end plate potential that occurs, and this leads to muscle fiber contraction. On the right-hand side of the screen is a little bit more of a close-up of the acetylcholine receptor and the scaffolding apparatus itself. So in the middle, with the arrow pointing to it, is the acetylcholine receptor, which is composed of 5 subunits, and the 2 acetylcholine molecules bind to the 2 alpha subunits. Most autoimmune myasthenia gravis is due to IgG1 antibodies directed against the acetylcholine receptor. And these antibodies cause a few effects. There is complement activation, and so there's destruction of the integrity of the neuromuscular junction. There is also cross-linking of the antibodies with one another, and so acetylcholine receptors sort of cross-link abnormally and then are endocytosed. And then also there's probably some degree of actual blocking of the acetylcholine binding sites by the antibodies, but that isn't necessarily the primary mechanism of disease. Muscle-specific kinase, or MuSK, is another protein that's implicated in autoimmune myasthenia gravis. So a lot of patients that were previously thought to be seronegative have actually turned out to have antibodies to MuSK. This disease is a little bit different, as we'll talk about in a later slide. There can be minor differences in terms of the presentation, but then this is actually an IgG4 mediated disease, so it's a different subclass of antibody that does not activate complement, and that has kind of some important treatment implications as well. Autoimmune myasthenia gravis caused by antibodies against LRP4 has also been documented and described, but LRP4 isn't commercially available as a test at this point, so it's not really something we'll talk about much. So clinically, patients with myasthenia gravis and pediatric patients in particular will very, very frequently have cranial nerve injury. So 95% of patients will have oculomotor involvement and ptosis at some point throughout their course. Ptosis, ophthalmoplegia, facial weakness, and bulbar weakness are extremely common. And so if you have a patient that is extremely weak but doesn't have these findings, then I would definitely be thinking about something other than myasthenia. These patients can progress to have respiratory weakness quite quickly, and the respiratory muscles can be involved quite out of proportion to the extremity skeletal muscles. And so Patients can have proximal weakness, but this often is pretty mild compared to bulbar and respiratory weakness in patients in crisis. They should have intact sensation, reflexes should be intact, and then the other important clinical feature to look for is significant fatigability. So with repeated movement, with sustained upgaze, patients will develop weakness even if they initially have normal. Like I mentioned before, MuSK myasthenia can look very similar to acetylcholine receptor binding antibody myasthenia, but patients can have some differences. So they often will have more prominent bulbar symptoms. They can actually develop muscle atrophy involving the tongue, which is pretty uncommon in acetylcholine receptor myasthenia gravis. These patients are much more likely to have generalized myasthenia as opposed to restricted ocular, and they tend to have more severe disease at onset and at nadir. They're more likely to have crises, and so you may want to think about testing for this initially if a patient is presenting for the first time with pretty severe weakness. They have less response to acetylcholinesterase inhibitors and less response to corticosteroids, and this is probably because, as I mentioned before, antibodies to MuSK are of the IgG4 subclass, which does not activate complement, and steroids have a lot of effect on kind of complement activation. And so that's just a different disease mechanism that steroids aren't targeting. Fortunately, these patients do respond very well to rituximab, and so that, is definitely a treatment choice that should be considered early in a patient with MuSK myasthenia. In a patient who you're suspicious of myasthenia gravis, I've outlined the workup here that you should consider. Acetylcholine receptor binding antibodies can be sent from the serum. Most people have probably also seen that tests exist for modulating and blocking antibodies as well. Those are not very sensitive or specific, so there's a lot of false positives and a lot of patients who have myasthenia who don't have those antibodies. They're probably most useful when they occur along with acetylcholine receptor binding antibodies, and that's probably their main role of pathogenesis. And so I really don't send those other types of antibodies unless there's a patient who is, seronegative and I have a very high suspicion for myasthenia. So we really only need to send the binding antibodies because they are so much more commonly positive than MuSK. It's probably reasonable to just do the acetylcholine receptor antibodies first, and then if those are negative, you can look for MuSK. Clinically, you can give patients an acetylcholinesterase challenge and see if they improve. Classically, this was done with edrophonium IV, but this, isn't done very often anymore, but it is an option. EMG nerve conduction study should be done with repetitive nerve stimulation, and you'll see, as I've illustrated on the right here, a decrement in the CMAP amplitude with repetitive nerve stimulation. I'm going to talk about that a little bit more here in a minute. Single fiber EMG is another test that can be performed if you're having a hard time making a diagnosis of myasthenia, but that's really something more for kind of an outpatient workup and not quite as relevant for patients presenting with acute crises. All patients should have a CT of their chest due to the high incidence of thymoma and thymic hyperplasia in patients with myasthenia gravis as well. In pediatric patients, an important differential is congenital myasthenic syndromes. So while these patients are more likely to present with a more common a more chronic course, they can present in crises that are precipitated by illnesses and things that cause autoimmune myasthenia gravis crises, and so it's something to think about in children and young. So I wanted to take just a minute to talk a little bit about the decrement that we see on repetitive nerve stimulation, because this wasn't really a concept that I understood very well until how to do the electrodiagnostic tests, and so I think there's probably some learners who don't quite understand the mechanism behind it, and when you understand it, it actually helps explain the fatigability that you see in myasthenia gravis as well. So going back to this picture of the neuromuscular junction, Remember, there are vesicles of acetylcholine in the motor nerve terminal, but these are actually present in three different stores. So there's the primary store that is kind of ready for immediate release as soon as the motor nerve depolarizes. These vesicles of acetylcholine are released across the synaptic cleft and interact with the postsynaptic membrane. But there's also a secondary or mobilization store that isn't readily available, but pretty quickly, if they're repeated muscle contraction or repeated motor nerve depolarization, these can be mobilized and then released. And then there's also a reserve store that takes quite a bit longer to access, but is still there. So in a normal, healthy individual, there is something called the safety factor that allows you to contract your muscle over and over again, continue to release acetylcholine, and still generate the same amount of muscle force that you do even with the very first contraction, even though you're sort of depleting your stores of acetylcholine that we just talked about. So the idea behind the safety factor is that for a muscle membrane, the resting membrane potential is typically around -70 or -80 millivolts. In order to generate a single fiber muscle action potential, there needs to be a change in that resting membrane by about -15 millivolts. And so when the acetylcholine receptors are activated, they open up sodium channels, which allow for influx of sodium, and there's a change in that membrane potential. Now, the change in the membrane potential and what's generated by the acetylcholine receptors is called the end plate potential. And that potential is actually usually 5 times what is needed to generate the muscle fiber action potential. So 4 or 5 times that change of 10 to 15 millivolts. And so regardless of how much acetylcholine you release, most of the time the end plate potential is going to be large enough to generate an action. However, in patients with myasthenia gravis, there are less acetylcholine receptors and less functional acetylcholine receptors on the postsynaptic membrane. And so at baseline, that safety factor is reduced. And so even though your nerve terminal is releasing the same amount of acetylcholine as you would in a healthy individual, the end plate potential is quite a bit less, even to start with. So this first box here is looking at repetitive nerve stimulation in a healthy individual. So the N box is the number of acetylcholine molecules released. The M is the change, so the reduction in acetylcholine that's going to be released with the second stimulation because you're sort of depleting your acetylcholine stores. The EPP is the end plate potential, so that 40 millivolts is the first one. Whether or not a muscle fiber action potential is generated is indicated by the plus or minus, and then whether or not a CMAP occurs depends on if the muscle fiber action potential is generated. So in a normal person, 1,000 quanta of acetylcholine are released, an end plate potential of 40 is generated, an action potential occurs, and a CMAP occurs. With the second stimulation, only 800 quanta of acetylcholine are released, but the end plate potential is still 32, which is more than double what is needed to generate a muscle fiber action potential, and so there's a normal CMAP. With the third stimulus, 640 quanta of acetylcholine are released. There's still an adequate end plate potential, same outcome. The fourth stimulus results in the smallest end plate potential, but it's still adequate. And then once you get to the fifth stimulus, you start to mobilize those secondary the mobilization stores of acetylcholine. And so you'll see it, the quanta actually go from 512 to 640. And again, you have a very adequate end plate potential to generate a normal CMAP. Now, in a patient with myasthenia gravis, kind of the same setup in that second box there, you still have 1,000 quanta of acetylcholine that are released with the first stimulation, but because of the abnormal acetylcholine receptors, the end plate potential is only 20 millivolts to start with. So this is still adequate. This is still enough to generate a normal CMAP. Clinically, this is still enough to generate, maybe a normal extraocular movement to begin with. But as we move down, very quickly the end plate potential falls below what is needed to generate a muscle fiber action. And so we start to see a decrement in the CMAP amplitude. But again, with the fifth stimulation, there is actually an increase again in the end plate potential because of mobilization of those secondary acetylcholines. So this is what leads to the classic U-shaped decrement that we see in myasthenia gravis, and it also explains why patients may be able to give you a normal strength amount of force on initial testing, but then will fatigue with repeated testing. So things that can cause myasthenic crises or exacerbate disease include illness, pregnancy, and kind of a whole host of drugs. So I do think it's reasonable to tell myasthenic patients that, if your doctor is thinking about starting a medication for you, it might be reasonable to talk things over with your neurologist first, or at least look it up. In general, antibiotics, patients are going to need them, and so that patients should be treated appropriately for their infections, but patients should just be aware that there's a lot of medications that can interfere with neuromuscular transmission. If patients do come in with crisis, similar principles to what we talked about in patients with Guillain-Barre Syndrome, then these patients with neuromuscular weakness can have kind of a different look to them than typical patients with impending respiratory failure. And so monitoring your NIF or MIP and FVC are important. You can also watch blood gases, pulse ox, and monitor their swallowing. On exam, neck flexion probably correlates reasonably well with other bulbar function and respiratory weakness. Once patients start to get a very soft, hypophonic voice, that's a sign that, they may need to be intubated. And then again, this feeling of anxiety and air hunger. These patients, may need to be intubated sooner rather than later as well. If there is an infection causing the exacerbation, that should be treated. Most of the time, especially when patients are intubated, there's not really a reason to be giving them a cholinesterase inhibitor. That can sometimes cause increased secretions and is really not going to get at the underlying treatment of these patients. You want to treat these patients with plasma exchange or IVIG. There's sort of some debate as to what you should use in myasthenic crises. Some people are pretty dogmatic that if a patient is ventilated, mechanically ventilated, you should use plasma exchange because it works faster. When they actually looked at this in a randomized controlled trial of patients with treated with either IVIG or plasma exchange with moderate to severe myasthenia, there was actually not any statistically significant difference on short or long-term improvement. And so because plasma exchange can have more complications, some people use IVIG. I was kind of taught that if a patient is very sick, to use plasma exchange, and so that's the way that I tend to lead. If patients are not already on steroids, if this is kind of their first presentation, then steroids should be initiated once appropriate treatment with plasma exchange or IVIG has begun. There's also a little bit of debate between whether you should start very low and slow and kind of ramp up the dose or start with a high dose. There's kind of a dogma out there that high-dose steroids can cause myasthenic crises, and it is definitely shown that it can worsen weakness. However, some of the patients that have been described with this probably actually had myosin loss myopathy, and when they looked at this in a systematic way, the exacerbations due to steroids are they're there, but they're mild to moderate. And so it may be worth getting the patient's disease under better control with higher dose steroids. Again, my practice has actually been to do more this low, slow ramp up because that's what I was taught, and I think that it was reasonable and works well. Even if you don't start steroids, the plasma exchange or IVIG will be adequate treatment for 3 or 4 weeks. And so there is a little bit of time to get the steroids on board. But it is important to initiate another treatment besides the plasma exchange or IVIG because, like I mentioned, that effect is only going to last 3 or 4 weeks. Patients should then be weaned off their respiratory support, and then it is reasonable to think about treatment with rituximab in patients with MuSK antibodies, particularly if they're presenting, for a second or third exacerbation and they haven't had enough steroids. Quickly, I'll talk about infantile botulism. This is another thing that pediatric neurologists will see, although it's rare. Most commonly affects infants between ages 2 to 6 months. Patients universally present with constipation and progressive weakness that tends to affect the cranial nerves and bulbar muscles first. Patients can have autonomic symptoms, respiratory failure, and they may or may not have loss of reflexes, but typically do eventually develop loss of reflexes. This is caused by Clostridium botulinum toxin. Most commonly, the toxin serotypes that cause infantile botulism are A and B, and as opposed to the postsynaptic neuromuscular junction disease, Myasthenia gravis, this is a presynaptic NMJ defect where the toxin actually cleaves the snare proteins that are responsible for acetylcholine vesicle fusion with the membrane and release of acetylcholine, the synaptic cleft. While classically this is caused by honey exposure to infants, more recently, since there's been education about avoiding honey in the first year of life, this is more commonly due to spore exposure in the soil. This can be a clinical diagnosis. You do want to rule out mimics like GBS, spinal muscular atrophy, metabolic disorders, sepsis, things like that. There is a stool toxin assay, but it often takes weeks to come back, and so you want to make the diagnosis and start treatment sooner than that. EMG nerve conduction study can be very helpful in ruling out some of these mimics, and then also can actually show, as opposed to the decrement that we just talked about on repetitive nerve stimulation, it can actually show an increment when you do 50 hertz repetitive nerve stimulation, and this is due to sort of just flooding the neuromuscular or the motor neuron end plate with calcium from repetitive stimulation, which finally just sort of forces some acetylcholine out into the neuromuscular junction. Treatment should be with botulism immunoglobulin. This was shown to be, very safe, reduce hospital stay and reduce ICU stay. With or without the immunoglobulin, it's a very good prognosis, but the immunoglobulin greatly reduces the amount of time the patient's in the hospital and hastens recovery. So again, here's the CME code, and I'm happy to take any questions.
Dr. Rogers, I just had a quick question about infantile botulism and Zarbee's. It's like one of the natural honey-containing cough suppressants that they market for babies like 4 months and up. I've never heard of that specifically being associated with botulism, but have you seen that or heard of that, or is that something we should warn our patients against or ask about specifically as opposed to honey?
Yeah, I have not heard of that causing botulism. I would be curious. I wonder if they do something to the honey, that because if you heat the spores to 120 degrees, I think it kills them. So potentially, I guess if it was processed correctly, it would be okay. But I would definitely want to look into that and know that they were doing.
Amanda,
Thanks.
Can you hear me?
Yes.
This is Martin Brown. Thank you for the great talk. I love the topic. I'm a little biased, but at Children's Hospital, I was told by one of the pediatric neurology residents that you all have and pretty commonly use cap gas, capillary. You can order a cap gas, and it can be done at bedside. And that actually would be a very quick way to measure CO2 retention or to detect CO2 retention. And I'm wondering if that is something that was ever used at WashU, and is that something that you would consider adding to the vital signs of patients who are being monitored closely?
Yeah, that's a really good point. Yeah, that is something that we used. And I guess I should rephrase what my recommendations to the ICU would typically be monitor these things every 4 to 6 hours, and then they would kind of make the decision on how to best do that, whether that be an ABG or a cap gas. But especially in young patients where they may not be able to cooperate with the pulmonary function testing, I think that's a great way to kind of monitor their respiratory function. They also actually they have like Untitled CO2 monitors that can just go in the nose now as well, or just be on the mouth, so the patients don't have to be intubated for those. So we would use those commonly as well to get a good picture.
We have a similar problem with the NIF, doing the NIF study in adults, in that it's effort dependent, and sometimes we have some psychogenic patients who have really bad myasthenia, and the NIF would be look really bad. But if you do an Untitled, or if you get an accurate Untitled, or if you do a blood gas, it's a whole lot more objective.
Yeah, that's a good point.
But thanks again for the talk.
All right, well, if there aren't any other questions, I guess we can wrap up. Everybody have a good day.